Good morning, and thank you all for coming to this session so early. First, I would like to thank the organizer for inviting me to come and speak at this very nice conference. And once again, congratulations to James and Simrit for putting on such a good show. It's really a pleasure to see how this meeting has grown from strength to strength every year. So this morning, I'm going to talk to you about gene expression profiling in myeloma. And to start, just some molecular biology 101. So the central dogma for molecular biology for since the beginning of time really has been that DNA is being transcribed to mRNA, which is then translated into proteins. So this has been the way that biologists have been studying pathways and genes for many years. But clearly this is inadequate because it's like a blind man feeling a different part of an elephant, and you don't see the whole picture, and depending on what you're studying, you have a very biased view of what's in front of you. And clearly this is inadequate to study cancer because the molecular circuitry of a cancer cell is highly complex. There are many aberrant pathways that actually intersect with one another. So we really need to move from a linear way of studying gene and its pathway to a highly parallel method where we can look at all the different genes and pathways at the same time. And this became possible at around the turn of the millennium with the completion of the draft human genome sequences and the availability of technological advances such as we can do microarray experiments and look at the whole genome changes all at the same time. And this has benefited biology and the study of cancer across the board, but in myeloma, we have really embraced this technology in a big fashion. And over the last 10 years, really a large amount of data and results have come out of these kind of studies, which actually to most physicians may be quite confusing because there's a lot of information out there. And so over the next few minutes, I'll take you through some of the key findings, the key utility of gene expression that I see is possible in myeloma. So one of the most useful use of gene expression is actually in trying to identify the subtypes of the disease, because based on the expression of large number of genes, you can actually see patterns of expression that identify different molecular subtypes of the disease. So again, here is one such study from the University of Arkansas where using unsupervised methods, so they did a large number of gene expression profile on a large number of tumors, and they asked the algorithm to tell them how to group them together based on expression pattern. And you can see here that they identified a number of subgroups. And in fact, most of these subgroups are driven by the primary genetic events that we find in myeloma, such as the translocations, such as hyperdiploidy. But in the process, they are able to identify unique and novel subgroups as well, such as the low bone lesion subgroup here and the proliferative subgroup here. And more importantly is that these have all got prognostic relevance. When I was at the Mayo Clinic, applied such technique to look at hyperdiploid myeloma, which is one of the most common genetic subtypes of myeloma, affecting about 50 to 60% of patients. And we had this idea that perhaps within this large group of patients, further subcategories exist, just like diffuse large B-cell lymphoma was found to have at least 2 different or 3 different subtypes. We found similar kind of things in hyperdiploid myeloma, where we can use gene expression to identify 4 subgroups of patients. And looking at the gene expression, for example, this group here has a high expression of NF-kappa B gene. This turned out to be relevant because this group of patients in clinical trials of Velcade has the best response and outcome. And then over here, you have a group of patients that express cancer testis antigen and proliferation genes that actually has the worst outcome. So despite the fact that hyperdiploid myeloma is supposed to be a good risk subtype of myeloma, this group of patients has survival here of only about 2.5 years. And so you can use these techniques to further tease out, even within well-known genetic subtypes of myeloma, that is clinically relevant and also relevant to therapeutic outcome. The other area that we have done a lot of gene expression studies in myeloma is in terms of prognosis. And compared to traditional biochemical factors and clinical factors, really gene expression-based prognostic signatures has been very, very powerful. So over the last 10 years or so, a number of these have been identified and published, and I list them down here. Some of them have been identified coming from the direction of what is the major gene expression difference between very good patients with very good survival and those with very, very short survival. So the University of Arkansas did that, the IFM group did that, and they identify a signature coming from the perspective of what is different between good and bad. Whereas other groups, such as us and the French, as well as the British group, have actually looked at the question from the perspective of biology. So we were interested in studying abnormal mitosis. The French group here studied the effect of IL-6 stimulation of myeloma cell lines, and the British here look at what are the genes affected by biallelic deletion or homozygous deletion in myeloma. And these different groups, approaching from a biological perspective, have actually identified different very strong prognostic index that is independent in different data sets as well. And more recently, we have identified a signature associated with genomic instability, again, highlighting the importance of genetic aberrations and the importance to prognosis. But really, these, proliferation of gene expression indices associated with poor prognosis is highly confusing. So how are they related to one another? Are they telling us the same thing, or they are telling us different aspects of biology that may be associated with poor outcome? And so this analysis is very recent. In fact, I just put up this slide yesterday while preparing for this, is that when we look at these high-risk signature that I've mentioned in a previous slide, and each of these blue bar is actually the component genes of these gene expression signature, you can see that there are only very few genes that exist in more than 2 of these gene expression signatures, such that when we look at shared genes, there's only 5 of them. And each signature would have a unique set of genes that is actually non-overlapping. That suggests to me that these different gene expression signature could be also identifying different aspects of biology that may be associated with poor risk. So why not we put them together and see, whether if you have more than one, it is worse than when you have one. And so that's what we did. And this is data from the University of Arkansas data set, large number of patients, more than 400 patients treated on total therapy. And here, each of the row represent the presence or absence of one of these high-risk factors, such as amplification of CKS1B on 1q21, the presence of 414 translocation, MAF translocation, proliferation index, centrosome index, and all these other gene expression high-risk signature. And each column represent a single patient. So when they have red, it means that they have these high-risk signature. And we can do a simple count across all these different signature, and you see that clearly you can group patients to those that have either 1 or 2. Very few of these high-risk factors, and over here are patients with a large amount of these high-risk factors. And you can also see that for some of the high-risk gene expression signature, really not every single one of them are grouped on this side of the heat map. And there are some so-called high-risk patients identified by these different factors that actually is clustered over this side. And when we look at how this impact on survival in a different data set, you can see that the survival curve do break after you have acquired a certain number of these poor risk factors, such as very clear break lines can be seen at the level of having 4 or more of these risk factors. And when I simplify this survival curve to just those with 0 to 4 factors or 5 and above, you can see a very clear separation of these survival curves. And this is very consistent across the different data set, and I'm just showing 2 of these down here today. And so we hope that this kind of analysis would allow us to clarify and simplify the utility of these prognostic gene expression signature and make it easier for physicians in the community to interpret this kind of results eventually. It also offers us new therapeutic avenues, especially in the understanding of some of these high-risk groups. So as I said before, we have worked with a centrosome index which identify patients with high risk. And what we did was we just asked a simple question, what are the gene expression differences between these high-risk patients and those with good outcome? And this is one such heat map, and again, every row represents a gene and every column a patient, and those Patient clustered on the right-hand side of the graph are those with high centrosome index and high risk, poor survival, and those on the left side are those with low risk. And clearly, we can see, gene expression that are different. Some of them are, as I said before, the cancer testis antigen proliferation. But we also saw that there was increased expression of aurora kinase gene. And at that time, with the publication of this paper, aurora kinase really hasn't really been studied in myeloma. But we knew that in cancer, generally, aurora kinase is emerging as a target for cancer therapy. So we first validated that, indeed, aurora kinase is overexpressed at the protein level in myeloma. And when we worked with the cell lines using a Millennium aurora kinase compound, which actually turns out to be now in full clinical development, and some of you may have heard the talk yesterday, there was increased responsiveness for cell lines that have high expression of this centrosome index, showing as a proof of concept that indeed we can perhaps target aurora kinase for this high-risk group of patients. And the last aspect I want to talk about is really in the area of predictive markers. And this is quite different from the prognostic markers that I've mentioned before. And so we've done a lot of work in terms of looking at prognosis, but really that doesn't tell us whether these patients individually is going to do better with certain therapy or not. And so that's the difference between prognosis and predictive marker. Prognosis can tell you that this guy is going to do badly overall, they're going to have a short survival, but you have no way to tell you whether they will respond better to Velcade, Revlimid, or other therapy. Whereas a predictive marker, what we hope to achieve would be that you have a marker at diagnosis that will allow you to select patients for certain drug treatment, and they will have a better response to those drug treatment. And again, this is work done at the Mayo Clinic led by Leif and Raphael when, they did a whole genome array CGH analysis looking at aberrant genes that are deleted in this analysis in myeloma. And they found that, to cut a long story short, that NF-kappa B pathway contains a large number of genes that are either deleted, mutated, or amplified, such as in the overall consequence of any of these aberrations is that there's a constitutive activation of the NF-kappa B pathway. And we know that one of the ways that perhaps Velcade could be acting in myeloma is through the targeting of NF-kappa B, although this is by no means the main mechanism that we think nowadays, that perhaps patients with these mutations that are addicted to the NF-kappa B pathway would be more sensitive and have a better outcome to Velcade. And indeed, this is what we found in the APEX gene expression data set. So these are patients entered into the trial comparing Velcade to dexamethasone in relapsed disease. We find that those patients with a low expression of TRAF3, which is one of the most commonly mutated of the NF-kappa B gene, has a remarkable 95% response to Velcade, whereas those randomized to dexamethasone only have a 20% response, and this translated into a significant improvement in the survival of these patients, whereas those patients with a normal TRAF3, actually there is no difference between the treatment outcome to dexamethasone or Velcade. So this is perhaps one of the ways that we can use gene expression to identify predictive marker, and I'm hoping that this work would actually get translated into the clinic one of these days. This publication is now about 4 years ago, and I'm still waiting for more publication on this aspect of Velcade treatment. So I've told you what are the potential utilities, some of the very interesting and significant finding, but the more important question maybe to most of the audience here is, can we ever see the use of this kind of information in the clinic? And I think the barrier mainly here is the fear of touching gene expression data, all those heat maps, the large number of genes, how do we deal with this information? And I think if we can take that complexity of analysis away from the practicing clinician and just give them a report with a yes-no answer, with a high-risk, low-risk kind of information, then it may actually make it much easier for them to accept and practice and use this for practice. And so the next few slides, I'm going to just highlight some of the things that are being done. And this is work largely pioneered by Rafael Fonseca, who's going to give you another different talk later on. And basically, they have generated an algorithm that could process the information from gene expression in an automated fashion and generate a report that looks something like this. And in this report, you will be able to get information about the subtypes of myeloma, whether they have hyperdiploid, whether they have 414 translocation, all based on gene expression analysis. You would get information of the risk signatures that I've mentioned before. So in this case, it's the Arkansas 70 gene signature, and you'll get a result and an interpretation, whether this tells you that the patient has high risk or low risk disease. You get other signatures as well that may help you to select patients for treatment, such as the NF-kappa B index that may predict for response to Velcade. And on top of that, you get things that may be useful to help you interpret, such as how contaminated this sample may be, how reliable this result is going to be. So hopefully, with this kind of implementation, it will give the physician a report in front of them, just like a FISH report, a cytogenetics report, that help them make clinical decision. And certainly working with the Mayo Group over in Singapore, we are starting a prospective validation of this kind of methodology in real time to look at how it is better than current method in terms of accuracy, in terms of turnaround time, in terms of health economy, and how feasible the implementation of this kind of workflow is to the treatment of myeloma patients. So we will consent all patients to have their bone marrow and peripheral blood collected. We have a comprehensive tissue banking system, which I'm not going to talk about. But basically, after selection, the CD138 positive cells will be subjected to RNA extraction and gene expression profiling, fed into this automated analysis system, and then the report is generated. And of course, we are still refining this automated system because the analysis that I just shown you, where we can combine these different signatures into a risk count, is something that's quite new. So, but you know, we can always add on these newer analysis to this kind of framework. So in summary, I'm just going to tell you that gene expression profiling is a very powerful tool. It is powerful and useful for the diagnosis of myeloma patients, subtyping, to potentially individualize treatment for patients, and to identify patients with good and poor outcome. And it is perhaps possible in the coming 3 to 5 years where these can become implemented clinically. So I would just like to make a few acknowledgements to the people in my lab that is doing work in myeloma now, and also to acknowledge collaborators from the Mayo Clinic, especially Rafael Fonseca, who has for many years been my mentor. And a lot of the works that I've talked about in my talk actually was work done when I was at the Mayo Clinic, and you know, some of the newer stuff still work done in collaboration with them, and my funding agencies in Singapore that make this work possible. And lastly, as a plug, just to tell you that if you are not tired enough of hematology in Asia, there is another hematology congress in September in Singapore. And for those who are interested, this is the website that you can go to find out more information regarding registration and content. So with that, thank you very much, and probably question later. Thank you.
So we have time for questions.
Oh, great, thanks.
So we have time for questions, and so I mean, this is excellent work, and I think you hit it exactly as how do we bring this to practice? I mean, so we now have like 7 gene expression profiling risk categories. How much more do they add to just the standard FISH and conventional cytogenetics? I mean, does it actually going to change what we are going to do with the current instruments we have available?
Yeah, I think that's a very, very important question. Based on our analysis, it suggests that the gene expression is always more powerful than you know, the conventional cytogenetics. And we know that even for 414 patients, there are data suggesting that you could further divide those patients into those that are good 414 and those that are really bad 414. And so this kind of analysis, where we really put the gene expression signatures together with conventional parameters such as the ISS staging, the cytogenetics, the FISH, into a large multivariate analysis to look at what is the contribution of each factor, is currently ongoing as part of the International Myeloma Working Group studies.
But you're still treating everybody with triple therapy and a transplant.
That's right. But I think the ability to identify high-risk patients is perhaps not that clinically useful now, but is useful for the study of a high-risk group of patients that clearly current available treatment is inadequate. So if we do not do that, then, and we continue to treat everyone the same, then we'll never improve the outcome of the high-risk patients.
Dr. Coleman?
As an extension of what Sergio said, when we look at a gene expression profile, I think so many of those genes are really epiphenomena. There must be certain very critical genes that are really making the difference here, rather than there being 150 genes. Maybe there are really 5 of that 150 that really turn the system on. And when we look at large cell lymphoma, and although there is some controversy, using gene expression profiles, we've divided them into ABC, GCB, and other. But we have algorithms now, just looking at CD10, BCL6, and MUM1. Now, it may not be a perfect algorithm, but it seems to work fairly well in distinguishing these entities. Is it not possible that we'll be able to do the same thing with myeloma? In other words, the gene expression profile is beautiful and it looks nice, but I'm not sure that all those genes really make a difference. They may just be secondary phenomena. How do you respond to that? It was very much what Sergio was saying.
Yeah, I think, in the area of lymphoma, there's always been this push to actually simplify those gene expression down to a few genes where you can apply multiplex PCR or like immunohistochemistry method. That really hasn't been done that much in myeloma, so I cannot answer that question directly, but looking at how little overlap there was in those genes, I would suggest that this is not the easiest, and myeloma perhaps is really much more heterogeneous a disease as a whole than large B-cell lymphoma. So I think biologically there may be limitations, and the different treatment that these different data sets are subjected to, and the different kind of stage of the disease, or centers performing the analysis may also have an impact. So I think there is a move from the community to try to harmonize and make an analysis where we could have some meaningful, conclusive data as a community that can be applied generally.
Dr. Sugarman?
A very nice talk, and I have to thank Morton, the organizers, him giving the equivalent talk in lymphoma this afternoon, and it was very interesting but very difficult almost to grasp because of the complexity. I thought I'd make one comment, I think you answered it just now, is that with the forms that are being developed over, say, at the Mayo Clinic and yourself and your group, is the complexity is that as the drugs we give patients may influence the results we see, we may be changing the biology of the tumors depending on their exposures. So we always have to keep revalidating these forms as we do them. And one last comment is that it's not only, when I saw you said the percentage of plasma cells were analyzed, I think that the other thing that we probably learned also yourself is that it's also an influence of the microenvironment and the immune response. So therefore, I think that we can't exclude any of those. It's actually much more complex. I think that who knows what, somehow we need to try to streamline it, but I think there's many influences that we have to keep in mind. It's the complexity of the issue.
Yeah, absolutely agree with that. And, I would also say that a lot of the analysis is done on the older kind of data sets. So as the new treatment data sets are emerging, we will always be validating these signatures prospectively as well.
Thank you very much, Dr. Chng.